फिर फोल्डर का वही नर्सिंग वाला ना? अच्छा MBBS। अच्छा वो तो उनका था, कल आए थे, उनका याद है। आज क्या है? डिजीज ऑफ जॉइंट्स, आर्थराइटिस है ना, जॉइंट्स ऑफ आर्थराइटिस।
ये 3:30 बजे है।
अच्छा वो अभी तो नहीं है ना?
नहीं, 3:30 बजे।
वो 3:30 वाला तो हो गया हमसे दोनों से, जो आपके साथ के
हुआ, लेकिन वो कुछ
इधर ही है ना,
यहाँ पर ही है, होंगे तो यहाँ पर।
अब मेरे को बता देना जैसे भी अगर कुछ चेंजेस होता है।
चेंज तो और कुछ नहीं होंगे, कोई आएगा नहीं आएगा, मैं 3:30 बजे आ जाऊँगा,
ठीक है,
प्रेजेंट कर दूँगा।
कोई नहीं, मैं तो इधर ही रहूँगा। नहीं वो मैं कल इसको डालना है ना।
अच्छा,
ठीक,
स्टूडेंट्स आ गए तो देख लीजिए।
हाँ वही देखना था, इसीलिए मैंने वो किया था देखने के लिए, वही तो हो गया होगा। अभी लॉगिन नहीं किया,
नहीं
जी करेंगे, स्टार्ट करते हैं।
ठीक है। कौन से पत्र भेजे थे?
ये भेजा आ जाता है। मुझे लग रहा जगाना पड़ेगा उनको, जगाता हूँ, चलो करता हूँ मैं फ़ोन, मेरे पास ऐसे ही आता हूँ, नहीं तो आप अपना न्यूज़ पे रिपोर्ट करके चले जाना अपना। अभी तक नहीं किया किसी ने बोला क्या? सब सोते रहते हैं,
लाइव भी नहीं चल रहे,
नहीं लाइफ तो जा रहा है,
लेकिन
ये ना आप आ रहे,
ये देखिए, ये देखकर ना,
नहीं वो थोड़ा 1 सेकंड का वो रहता है। आप इसमें नंबर है किसी का तो ईमेल वगैरह कुछ करके देखो, मेरे पास तो ये नॉर्मल था, नंबर से यहाँ को उठाई नहीं रहा सीधा,
मेरे तो है नहीं।
चलो 2 मिनट और वेट कर लेते, शायद समझ मेरी मिस कॉल छूटेगी तो शायद देख कर शुरू कर देंगे, मैसेज पास कर देगा सबको। बच्चे आजकल टॉपिक देख कर पढ़ाई कर रहे हैं, नई टॉपिक शुरू से ही मैं देखता आ रहा हूँ, मैं डॉक्टर सफाया पढ़ाते थे ना शायद ये वाला भजन की क्लास में भी सब कोई आते ही बात नहीं हो गया शुरू। चलो ठीक है, एक इसी में शायद शुरू किया है।
Good morning everyone. Today we'll be learning about disease of joints, that is arthritis. Now, before going to main topics, you should know about certain questions about arthritis, like what is osteoarthritis, what is the pathogenesis, and what are the complications of osteoarthritis, what are osteophytes, hibernation, what is rheumatoid arthritis. Again, the pathogenesis and complications of rheumatoid arthritis are very important. What is loose body, what are rice bodies, what is Pannus, what are the extra-articular manifestation of rheumatoid arthritis. And crystal-induced arthritis is very important, especially gout. And you may be asked about the pseudo-gout, the difference between the two. And also infective arthritis, that is also known as septic arthritis. Sometimes it is difficult to differentiate among gouty arthritis and infective arthritis. So how to approach in that case and how to make diagnosis. And you must know about the pathogenesis, complications, and sequelae of septic arthritis. Now, we classify arthritis broadly in two categories, inflammatory arthritis and degenerative arthritis. But you must know, this degenerative arthritis, this is a misnomer. Degenerative means the condition where due to some process, maybe the aging process that happens normally, the tissue undergoes degeneration, and following that there is development of arthritis. But in reality, in this arthritis there is a component of inflammation, and that actively participates in the progression of disease. Inflammatory arthritis such like rheumatoid arthritis, juvenile rheumatoid arthritis, psoriatic arthritis, ACLE or sarcoidosis induced arthritis. Degenerative arthritis are basically osteoarthritis, ochronosis. Ochronosis happens because of deposition of pigment in the joints, in the soft tissue, and osteochondritis dissecans. There is also deposition of certain products in the joints, and following that there is development of arthritis like gout, pseudo-gout, hemophilia. Septic arthritis is basically because of, in majority of the cases, infection by pyogenic bacteria, but especially the staphylococcus and streptococci. But sometimes the gonococcal arthritis is also common, especially in young patients. Arthritis associated with rheumatic fever. Now, coming to the osteoarthritis, this is the most common form of arthritis, and this occurs because of wear and tear process. So previously we used to call it degenerative arthritis, but nowadays this has been misnomer because of ongoing chronic inflammation in this condition. The cause may be primary and secondary. In primary osteoarthritis, the exact etiology we don't know, and this arthritis incidence increases with age of the patient. The osteoarthritis is basically oligoarticular arthritis. Oligoarticular means when the involvement occurs in less than 3 joints, and about 5% of cases of osteoarthritis are seen in young individuals. There are certain predisposing conditions like injury or some developmental deformity of the joints, diabetes, ochronosis, hemochromatosis, obesity. All this can lead to osteoarthritis. So osteoarthritis is classified primarily in 2 categories: primary, where the etiology is obscure, and secondary because there is underlying cause, known cause like trauma, systemic disease, congenital developmental abnormalities, neurogenic problem, and previous infection. So it is important to distinguish secondary osteoarthritis from primary osteoarthritis, because if we know the cause and if we treat that, the prognosis is better. So osteoarthritis is usually localized, but it could be also generalized. It can involve one or two joints or few joints, or even generalized osteoarthritis, most joints. And it can involve any joint, but common affected joints are knees, hips, first carpometacarpal joints, interphalangeal joints, first metatarsalophalangeal joints, and joints, apophyseal joints, joints of vertebrae. And there is wide phenotypic variation in the form of age of onset, pattern of joint involvement, progression of disease. It varies from person to person and from site to site. Sometimes it is an incidental finding, and it is detected during radiological evaluation of some other unrelated cause. So what is the normal function of the joint? The normal function is to provide smooth gliding movement on the in the joint, and that happens because of presence of some fluid which provides viscosity in the joint. So lubricin, which is basically proteoglycan 4, which gives this smooth functioning of the joint, smooth movement of the gliding movement of the joints. Okay. So in joint, you could see there are bony ends, and there is cartilage. There is cartilage on either side of this space. There is potential space where we see the synovial fluid. Okay. So if there is some problems with the cartilage or alteration in the matrix or alteration in the composition of the synovial fluid, then there is damage to this cartilage, and there will be development of osteoarthritis. So regarding pathogenesis of osteoarthritis, there are different theories, biomechanical theories and biochemical theories. Biomechanical theories basically implies wear and tear phenomenon, and that happens because of micro trauma, and with aging there is slow maintenance of the health of the cartilage, and because of aging there is damage to the cells. So cell renewal is not appropriate. So there may be matrix softening, death of the chondrocyte, and these degenerated cells release different kind of cytokines and matrix metalloproteinases that lead to degeneration of the matrix as well as cellular component, and that gives rise to osteoarthritis. Biochemical theory implies that during the aging process, because of degeneration of the cell, there is release of the lytic enzyme and also inflammatory cytokines from the damaged cells. Inflammatory cytokines, already I have mentioned in previous lecture, these are basically interleukin 1, interleukin 6 and tumor necrosis factor alpha. So this leads to the recruitment of inflammatory cells that again releases several enzymes which degrade the components of matrix, and that lead to death of the chondrocytes. So these are the basic mechanism. So there are biochemical factors, mechanical factors, and genetic factors, so that lead to development of osteoarthritis. So these are the cytokines and prostaglandins which are released due to death of the chondrocytes or following death of the chondrocytes, and that lead to matrix degeneration and cell death leading to osteoarthritis. So what happens in the initial stage? There is chondrocyte injury, and that happens because of aging factors, genetic factors, and biochemical factors, and that lead to wear and tear phenomenon. So in the early osteoarthritis, what we see, normally the cartilage is smooth, you can see here, but in the early process what happens, there is damage to the superficial layer of the cartilage. So there will be some fibrillation of the cartilage because of damage to the cells, chondrocytic cells, and there is also some degeneration in the matrix in this layer, in the superficial layer. So the layer which is towards the bone, that remains unaffected, relatively unaffected, and during this time when the arthritis develops, arthritis is associated with pain, so the joint function is usually restricted. That also leads to development of some sort of osteoporosis, so some osteoporotic change we can appreciate. So in the early phase what happens, there is injury to the cells and also damage to the cartilage, and there is increased production of different kind of growth factors and metalloproteinases. So those leads to degeneration of matrix. Here you can see what happens in the early phase of osteoarthritis. There is chondrocytic injury. When there is injury, there is a normal tendency to regenerate or to compensate the loss of the tissue. So there is proliferation of chondrocytes. When there is proliferation, they form in the groups, they aggregate, the proliferation occurs in aggregate, we call it cloning of chondrocytes, regeneration. And there is also damage to the matrix, so we see some sort of matrix degeneration that is appreciated when we see more light or pale color, that indicates the matrix has more water content, and there is matrix lysis. There is also hypertrophy in the initial phase of osteoarthritis. There is also hypertrophy of chondrocytes. So you see large nuclei, bluish nuclei, large chondrocytic cells in the osteoarthritis in the initial phase, and also you see on the surface there is cracks, micro cracks, there is and fibrillation on the superficial surface. In late osteoarthritis, what happens, the damage to the cartilage is quite severe. So we appreciate the cracks even grossly, and we see the loss of the cartilage grossly because there will be prominent thinning of the cartilage, and the tissue just beneath the cartilage, that is the bone, that becomes sclerotic, and the changes also occur in the bone bone adjacent to the cartilage. And what we see, there is also degeneration of the matrix in the bone, and that the mucinous degeneration that leads to formation of cystic component, that is the secondary cyst, which we see in the subchondral cyst, which we see in the bone near to the joint. So there is the cartilage is severely damaged, there is thinning of the cartilage, and the portion of the bone may be exposed to the surface. But during this process, what happens, there is also proliferation of the soft tissue, proliferation of the capillaries, proliferation of the fibroblastic cells with some sort of component of the inflammatory cells in the synovium. So that leads to hypertrophy of the synovium. So in late stage, there is severe damage to the cartilage, but there is also hypertrophy of the synovium, and the bone underlying the just beneath the cartilage is sclerotic, thickened, and there is also formation of the subchondral cyst. As the disease restricts the normal movement of the joint, we see the bone away from the joint is osteoporotic. So in severe osteoarthritis, what happens, there is severe loss of the cartilage. You can see grossly the cracks of the cartilage and the bony surface is exposed. So as the cartilage is thinned, the joint cavity is narrowed here because of approximation of end of the bone, and the bone becomes osteoporotic. So some of the tissue becomes weak. So as the ligaments are attached to the bony end, because of the ligamental pulling, there is formation of the osteocytes. And so this is the photomicrograph of late osteoarthritis. You can see there is severe damage to the cartilage and the bone is exposed on the surface of the joint, and you can see the bone adjacent to the joint is very thick, sclerotic bone, and the matrix, there is some sort of matrix changes with more collagen formation over here, and what is the tissue adjacent to the this area, the synovium, which is quite thickened. So here you can see the this is the synovium in osteoarthritis. The inflammatory component is minimum, but there is a mild proliferation of intimal cell and subintimal area showing collagen deposition, fibroblastic proliferation, and capillary proliferation with minimal amount of inflammatory component. And on radiograph, what we see narrowing of the joint, there is osteophyte formation, and when there is severe loss of the cartilage, what happens, both the bony ends come in contact and they form some sort of dense hard bone, sclerotic bone, and that gives rise to ivory appearance. This is known as everation. So what we see, narrowing of the joints, subchondral sclerotic bone, and osteophyte formation, osteophyte or phytes formation. What happens, because of hypertrophy of synovium, some of the tissue or fragmented cartilage may get dislodged within the joint cavity, and that form loose bodies. So loose bodies are found in osteoarthritis. There are several changes occur in osteoarthritis. These are basically ligaments, joint capsule, menisci, they are affected. Menisci may show degenerative changes and secondary cyst formation because of degeneration. There is disruption of the cellular matrix and loss of cell. Thickening of the joint capsule, tearing of the ligaments and menisci. This is quite common in severe osteoarthritis. And we see characteristic Heberden's nodes in osteoarthritis. So there are certain mechanisms how we can prevent this disease or delay the progression of the disease that you will learn during your surgery and from your medicine classes. Now this you should know, this ochronosis. This basically implies there is deposition of certain pigments in the soft tissue, including the joints. And this is a autosomal recessive condition where there is accumulation of homogenesic acid. This is basically metabolite of phenylalanine and tyrosine, and that leads to development of osteoarthritis. So you should know about the metabolism of phenylalanine. There are several conditions like phenylketonuria, tyrosinemia, and also this condition. In this condition, there is a deficiency of homogeneous oxidase. So there is accumulation of this pigment, and that pigment gives rise to some brownish or blackish pigmentation in the skin, in the sclera, and in the cartilage, hyaline cartilage. This condition can be diagnosed on the radiology, and they have the characteristic features, and in different stages there are different manifestation. So in severe condition there may be development of ankylosis involving the several joints, and grossly there is this pigment deposition. You can see ochronotic pigment, and clinician make the diagnosis grossly. So even when we get the biopsy material, the diagnosis come with the biopsy material. So what we see fragmented cartilage where there is deposition of this ochronotic pigment, and there is also some reaction. When the cartilage damage is there is reaction, usually the foreign body giant cell reaction we see in this condition. So there will be inflammatory infiltrate, foreign body type of giant cells, okay, and there will be yellowish brown discoloration of the tissue, the cartilage fragmented or degenerated cartilaginous tissue, and inflammatory cells. Okay. So osteochondritis dissecans, this is basically a self-limiting condition, and it occurs in children and adolescents. What happens? The portion of the bone just beneath the cartilage gets devitalized, and we don't know the exact cause, but there is loss of blood supply. So the etiology is not known, but definitely there is some sort of loss of blood supply, and some portion of the bone gets devitalized. So in the initial stage, if we manage, the condition will resolve, but if it is not treated properly, this can lead to development of osteoarthritis. Coming to rheumatoid arthritis, this is very important. This is an idiopathic chronic inflammatory condition, and it involves both articular and extra-articular components. This is very important for your exam purpose, theory purpose. Okay, even people may ask during Viva also. What in pathology Viva also, what is Pannus and what are the manifestation, what to get in joints. Okay. So this is basically non-suppurative proliferative arthritis, which leads to irreversible destruction of the joint. Joints means articular cartilage destruction of the bone, even the destruction of the tissue ligaments around the joints. There are several extra-articular manifestation like keratoconjunctivitis, tendinitis, cutaneous vasculitis, facial arthritis, osteoporosis, pericarditis, pleurisy, and so on. So in this condition, this is an inflammatory arthritis. You can see there is involvement of the joint, and there is component of vascular component, I mean the vasculitis that happens in rheumatoid arthritis. This is more common in female than male, and as the disease is progressive, there is irreversible damage to the components of the joints. In this condition, there is symmetric arthritis, and the manifestation may be acute, subacute, or there may be palindromic manifestation that happens in the form of recurrent episodes of oligoarthritis with no residual radiologic change, and there may be polymyalgia-like symptoms that occurs. The polymyalgia, I mean rheumaticalite syndrome, which occurs in elderly. That kind of manifestation also occurs in rheumatoid arthritis. I mean, it is difficult to distinguish whether this is rheumatoid arthritis or polymyalgia rheumatica. As the disease is symmetric, I mean the bilateral, so multiple joints are involved, but monoarticular presentation is also known. When the monoarticular, I mean the oligoarticular manifestation is there, the disease progression is slow, and it can form also in the form of acute manifestation. Extraarticular manifestation is basically due to vasculitis like tenosynovitis, bursitis, uveitis, that kind of things happen. And there may be malaise, fatigue, weight loss, fever. In early rheumatoid arthritis, there is symmetric polyarthritis involving primarily small joints of hands and feet with no radiologic change. So early manifestation is basically clinical manifestation without radiologic appearance. So there is commonly affected joints are metacarpophalangeal and proximal interphalangeal joints and wrist joints. These joints are usually affected. Distal interphalangeal joints, sacroiliac joints, lumbar spine joints, they are rarely affected, but when these joints are affected, you have to suspect about the seronegative spondyloarthropathies rather than rheumatoid arthritis. So there is criteria. There are criteria for diagnosis of rheumatoid arthritis, and revised criteria is there, and you must know this: the morning stiffness, arthritis of 3 or more joints, arthritis of joints of the hand, symmetric arthritis, rheumatoid nodules, serum rheumatoid factor, presence of serum rheumatoid factor, radiographic change. Among these findings, the 1 to 4, the criteria, they must be there for at least 6 weeks. But if we see any joint involvement which is symmetrical and bilateral, you have to investigate for rheumatoid arthritis. So related disorders are basically seronegative negative spondyloarthropathies, ankylosing spondyloarthritis disease, psoriatic arthritis, arthritis associated with rheumatic fever. Seronegative means in this condition there is no rheumatoid factors. Okay. So pathogenesis of rheumatoid arthritis, basically this is secondary. This is an autoimmune disease, but we don't know exactly. We don't know how this initiation of autoimmune process occurs, but certainly there are genetic factors and microbial genetic factors involved in this condition, and it is thought the condition starts in a genetically suspicious susceptible patient where the microbial agents may initiate the process, especially the viral different viruses like Epstein-Barr virus, retrovirus, paravovirus, mycobacteria components, which basically binds to the CD4 T cells, and that leads to auto-activation of this process. So what happens when this CD4 T cell is activated? It releases, activated by presentation of certain form of antigen, and that activation occurs when there is interaction, the presentation of antigens to the CD4 T cell. You know the antigen is presented by MSC class 2 molecules of antigen presenting cells. Antigen presenting cells, which are known as APC cell, they are basically monocyte macrophage cells are monocyte macrophage system. So when these cells present some sort of antigen to the CD4 cells, the CD4 cell will be activated and it will release some cytokines and certain other factors that lead to proliferation of other CD4 T cells and also activation of the B cells, and there is endothelial activation. So you know why there is vasculitis in this condition, because of endothelial activation in rheumatoid arthritis. So the cytokines, these cytokines will activate other CD4 cells and also other macrophages. So there will be recruitment of these T cells, and as there will be cell activation, that will lead to production of various antibodies, okay, including the rheumatoid factors, which is IgM. And there is formation of immune complex and immune complex deposition. So when there is immune complex formation and immune complex formation, that will be deposited in the microvascular system. So this also leads to vasculitis, and this deposition also occurs in the joint tissue, and this leads to activation of different pathways, including complement pathways, and there is inflammation, and that leads to damage to the components of joint. So in rheumatoid arthritis, what we see? We see the manifestation in the joint, skin and blood vessels. Okay. So in the initial stage, what happens? The synovium is edematous because of inflammation. There is thickening and hypertrophy or hyperplasia of the synovium because of proliferation of the capillaries, proliferation of the fibroblast, accumulation of the inflammatory cells, and edema. And there is perivascular infiltrate because of recruitment of several types of cells, including B cells, CD4 T cells, macrophages, okay, and the B cells differentiate into plasma cells, permanently differentiated B cells, which are basically plasma cells. These cytokines, several cytokines, inflammatory cytokines, which are released from these cells like macrophages and also lymphocytes, that leads to activation of the osteoclastic cells. So the osteoclastic cell will release reserve bone and release other matrix, I mean the degraded matrix component in the area. So this osteoclastic activity is associated with osteoporosis. So we see also osteoporosis in the bone around the joint. Okay. So there is articular erosion. The articular erosion occurs because of severe inflammation, osteoporosis, and severe damage, inflammation and damage due to the Pannus formation. So what is Pannus formation? Pannus is basically proliferation of the synovium with severe inflammatory infiltrate, and there is also proliferation of the fibroblast, proliferation of the capillaries. This leads to the damage to the cartilage, damage to the joint capsule, damage to the adjacent bone. So Pannus formation is associated with severe destruction of the bone. So there is erosion of the cartilage and destruction of the bone and ligamental tissue. So in severe condition, there is total damage to the cartilage, and there is proliferation of inflammatory granulation tissue in between in the joint, and there is fusion of the joint by this granulation tissue that leads to ankylosis, formation of the ankylosis. So in rheumatoid arthritis, what happens? There is marked damage to the cartilage and bone, but there is proliferation of the synovium, marked proliferation of the synovium. Because of proliferation of the synoviocytes, proliferation of the fibroblastic cells, capillaries, and there is marked accumulation of inflammatory cells including lymphocytes, B cells, and other cells in this condition. So there is hypertrophy, marked hypertrophy of synoviocytes. You must know in this condition there is also accumulation of acute inflammatory cells. Acute inflammatory cells mean there is accumulation of neutrophils in this condition, but neutrophils are seen in the superficial layer of the synovium. Neutrophils are not seen in the deep layer of the synovium. If you see deep layer of the synovium, you have to suspect there is associated complication like septic arthritis, complication by complicated septic arthritis. So in the synovial fluid and in the superficial layer of the synovium, you may get acute inflammatory cells, that means polymorphs in rheumatoid arthritis. So synovial proliferation can happen in the form of virus-like proliferation. Here you can see in severe rheumatoid arthritis, there is damage to the cartilage. Normally the cartilaginous surface is smooth, shiny, glistening appearance. Here you can see cobblestone like of appearance, and there is hyperplastic synovium. What happens? This hyperplastic synovium gets dislodged within the joint cavity, and they are encoded by the fibrin. In this condition, when there is flare, there is active inflammation, there is release of fibrin in the tissue. So this tissue get coated by fibrinous coating of this dislodged hyperplastic synovium, and that forms small bodies which are known as rice bodies, numerous bodies. So these are called rice bodies. So rice bodies are basically seen in rheumatoid arthritis, and loose bodies are seen in osteoarthritis. Never forget about this thing. What we see in histology, we see severe proliferation of synovium, severe hyperplasia, and this hyperplasia occurs because of proliferation of synovium, intimal proliferation, proliferation of the capillaries, proliferation of fibroblastic cells, and also accumulation of inflammatory cells. In this condition, what we see large number of lymphocytes and plasma cells. So B cells, they tend to form nodule, in the nodular aggregates, and there is differentiation of the cell into terminally differentiated B cell that forms the plasma cell. So we see a lot of plasma cells because these cells produce immunoglobulin, rheumatoid factor and various immunoglobulin. So there is marked proliferation of B cell in rheumatoid arthritis. You also see some neutrophils, but these neutrophils are present in the superficial layer of rheumatoid arthritis. There is also Pannus formation. So Pannus, what happens? There is active inflammation in the rheumatoid arthritis. What means? There is chronic inflammation associated with marked accumulation of polymorphs, neutrophils. So this leads to severe damage to the cartilage, bone, and the tissue, soft tissue around it. So Pannus formation is associated with destruction of the joint tissue. So over time there is total loss of joint tissue, and there is proliferation of granulation tissue, and there is fusion of the bone. So that is called as ankylosis. So initial tissue will be the fibrous ankylosis, but over time there may be calcification and ossification of the fibrous tissue that leads to bony ankylosis. You know the rheumatoid arthritis is having a component of rheumatoid nodule. So what is rheumatoid nodule? There is also vasculitis, and there is what happens? There is also inflammation. So in this condition, there is proliferation of histocytic cells. They form in the they are arranged in pseudo-palisading arrangement, or you can call it palisading arrangement. Usually pseudo-palisading arrangement, and in the center, because of ongoing inflammation, there is necrosis of the tissue. So we see the tissue debris surrounded by palisading histocytes, and around in the histocytic layer and around the histocytes, we see some sort of chronic inflammatory infiltrate. So this condition can involve several organs including lungs, spleen, pericardium, myocardium, heart valves, aorta, and other viscera. When these organs are involved, the prognosis is usually poor. The vasculitis, you see there is deposition of immune complex and also direct activation of endothelium. So there is inflammatory infiltrate, chronic inflammatory infiltrate, lymphocytes, plasma cells around the vessel. That leads to purpura, cutaneous ulcer, peripheral neuropathy, even the gangrene, nail bed infarction. You can see in rheumatoid arthritis there is symmetric polyarthritis especially involving the small joints of the hands, and also the joints of the hands of feet and joints of the wrist. Okay. So juvenile rheumatoid arthritis, this is also known as steel disease. People may ask you what is steel disease. Remember this thing. This is basically oligoarthritis, and it is more common in young patients. Here rheumatoid nodules and rheumatoid factors are usually absent, and but antinuclear antibodies present. There is genetic association, and the manifestation, the histologic manifestation is, even the clinical manifestation may be similar to the rheumatoid arthritis. There are several connective tissue disorders. This you have to remember because you may get multiple choice question from this area. Usually people will give one question, at least one question from here. Okay, so remember this association, rheumatoid arthritis and these factors, Sjogren's syndrome, and what are the antibodies, all these things. You have to know. Remember this table. Psoriatic arthritis, usually there is also involvement of joint in the psoriasis, and this is just you have to know, in psoriasis there may be arthritis, maybe polyarthritis, and that may mimic rheumatoid arthritis in psoriatic. HLA-B 27 associated disease, this you have to also remember this. There are certain conditions, we call it seronegative spondyloarthropathies. Okay, so these are the conditions we get HLA-B 27 abnormalities. Now you have to know three things together, and you should not forget about this. Gouty arthritis, gouty means gout and pseudogout. Gouty means deposition of monosodium urate. So gout, pseudogout, and septic arthritis. Because the clinical manifestation is almost similar, and people may ask you, how will you differentiate these three conditions? Gout, pseudogout, and septic arthritis. So crystal-induced arthritis. Crystal-induced arthritis are basically gout, which is due to deposition of monosodium urate in the joint. Pseudogout, which is deposition of CPT2, calcium pyrophosphate deposition disease. Okay, so gout occurs because of monosodium urate crystal formation. So there is more urate formation. When there is more urate formation, if the urate excretion is less and formation of more, or when there is excessive formation of urate, then during during that time there is formation and deposition of monosodium urate crystal, and that deposition usually occurs in the joint. Okay, So you have to know about the metabolism of this nucleic acid, okay, for this development of gout. People may ask you, and there are enzymes which are involved in this condition, and some treatment is also given so that the disease can be controlled in this, especially the xanthine oxidase or xanthine oxidoreductase. This you have to know, but you should know what is when the crystal formation occurs, when there is hyperuricemia. What is hyperuricemia? When the uric acid level is more than 7 mg per deciliter, okay, that leads to formation hyperuricemia, and in hyperuricemia there is deposition of monosodium urate crystal. Now what is the pathogenesis of gout in this condition? What happens in this condition? There is monosodium urate formation, and that monosodium urate binds to the toll-like receptor, toll-like receptor 2 and 4. So there is macrophage, they have this receptor, they binds to the receptor, and there is activation of NF-kappa beta, and also there is formation of inflammasome. This you have to remember, you should not forget. Okay, this is pathogenesis of gout, development gout, and progression of the disease. Okay, so monosodium urate can bind to the also cell membrane, and that can be also internalized within the cell. Okay, and there may be activation of the cell. Okay, so in this condition, when there is activation of NF-kappa beta, there will be production of inflammatory cytokines. Okay, so there is endothelial cell activation. Okay, and activation of formation of inflammasome, and its activation also lead to more production of interleukin B and release of this interleukin B. Okay, so it has phases, different phases. Remember this thing, there is initiation phase, then there is amplification, and after that there is resolution. Okay, so acute inflammation typically lasts about 7 to 10 days. So this is basically self-limiting condition. Okay, and in severe cases, what happens? There is persistent hyperuricemia. So there is deposition of more crystal in the joints. There is chronic inflammation. There is damage to the joint, and there is formation of tophi formation, severe damage. Okay, so initiation happens because of binding of the monosodium urate crystal with the toll-like receptor 2 and 4 on the macrophages. And amplification, what is amplification? Here is participation of neutrophil, because there will activation of inflammasome, and also NF-kappa beta activation. There will be recruitment of inflammatory cells including neutrophil. When this neutrophil interact with monosodium urate crystal, there will be amplification of inflammation. More cells will be recruited, more inflammation will occur, and more tissue damage will occur in this condition. Okay, and after that there is resolution phase. This is a self-limited condition. So after 7 to 10 days, the resolution occurs. Okay, and this happens because of formation of transforming growth factor. Okay, so transforming growth factor beta suppresses monocyte pro-inflammatory cytokine release. Okay, in release, and also it also suppresses the endothelial activation. So in gout, what happens? There is formation of monosodium urate crystal, that is needle-shaped crystal. Usually in normal tissue, which we see in our histology section, that is processed by using formalin and other substances. So monosodium urate crystal gets dissolved in formalin. So we don't see, but we can see some sort of material deposition, and there is inflammatory cells and giant cell reaction in response to the crystal formation that we see in gout. So here needle shaped crystal formation, and if we demonstrate the crystal, if you process the tissue using alcohol instead of formalin, we can demonstrate this crystal, and that will be like negative birefringence in gout. In pseudo gout, what happens? There is deposition of calcium pyrophosphate dihydrate in the joint tissue. Okay, the manifestation there are several conditions that can lead to pseudo gout formation. Basically, this is the secondary due to aging, osteoarthritis, and several other conditions you can see here. So the clinical manifestation of gout and pseudo gout, they can be asymptomatic, or there may be some acute intermittent manifestation. And gout, there is chronic profuse gout. There may be chronic profuse gout when the disease is progressive and persistent hyperuricemia. So in acute condition, it is difficult to differentiate gout from pseudo gout. Okay, but if you do the tissue diagnosis, you can differentiate these two conditions, because crystal formation of gout is different from the pseudo gout. Gout is having needle shaped crystal, and pseudo gout is having rhomboid shaped crystal or pencil shaped crystal. In pseudo gout, what we see the chondrocalcinosis. Okay, the calcium pyrophosphate deposition in the cartilaginous tissue components. So chondrocalcinosis. In gout, there is severe damage to the joint, so we can see the profuse formation, erosion of the multiple joints in gout. In pseudo gout, what we see? We see inflammation, and there is some bluish appearance, that is basically crystal formation. Okay, you can see here very big crystals. This is basically rhomboid shaped crystal or pencil shaped crystal, and there is also inflammatory condition. Now septic arthritis. Now septic arthritis can happen as because of disseminated infection to the joint, or because of hematogenous spread of infection to the joint, or it may be the complication in osteoarthritis and rheumatoid arthritis, or even in the gout there may be the complication. Okay, so in majority of the cases the etiology is basically staphylococcal or streptococcal infection, and root of infection is usually hematogenous spread. Okay, but direct infection can also happen because of if there is some penetrating wound in the joint, or if there is some osteomyelitis and that spread to the involved the adjacent joint, that can lead to development of septic arthritis. So in majority of the cases the etiology can be staphylococcal or streptococcal infection, but if the patient is young, you have to suspect about gonococcal infection, gonococcal arthritis. Okay, and if the patient is immunocompromised or no other degenerative disease is there, you have to think about streptococcal or staphylococcal infection. Okay, that's etiology. There are risk factors like rheumatoid arthritis, osteoarthritis, artificial prosthesis, intravenous drug abuse, alcohol abuse, diabetes, intra-articular corticosteroid injection that is given for osteoarthritis, some sort of ulcer over the joint. So in this laboratory investigation, what you get, because this is septic condition, so we get high WBC count, in elevated ESR and C-reactive protein. Okay, synovial fluid will show large number of polymorphs, white blood cell count, and microscopic examination you can see presence of bacteria. You can need to see when you do the gram stain, and also E2 culture you get the microbacterial component. Okay, so culture is done basically for bacterial growth and antibiotic sensitivity. If you aspirate, what happens in active condition of gout and pseudo gout, you also see large number of polymorphs. But if it is gout, you can see also crystal formation. Okay, you see monosodium urate crystal, and that is basically needle shaped crystal. But if it is pseudo gout, you see rhomboid shaped crystal or pencil shaped crystal you see in pseudo gout. That you have to remember. Okay, so you should be able to differentiate the condition, three conditions. Okay, gout, pseudo gout, and septic arthritis, especially when there is gout and pseudo gout is present in active formation. Okay, tuberculous arthritis, basically the tuberculosis you will know in your disease of this thing infection, but tuberculosis can also occur in the joint, Pott's disease, tuberculosis of any joint, knee joint, hip joint, okay, any joint. So what happens, there is granuloma formation in tuberculosis. Okay, there will be granuloma formation, and in the granuloma what you see, there is modified collection of modified epitheliate cells with giant cells, and in the center of the granuloma you see caseous necrosis. Okay, so people may ask you, what is granuloma? You have to know about the granuloma. What is definition of the granuloma? Granuloma is basically organized collection of modified epitheliate cells. Modified epithelial cells that should be collected in organized pattern. So organized collection of modified epithelial cells. Okay, the epithelial cells are modified because of influence of interferon gamma, which is released by TH1 cells. Okay, TH1 cells. The interferon gamma is produced by TH1 cells and NKT cells. So when the TH1 cell releases interferon gamma and activates macrophages, monocytes and macrophages, they are modified into epithelial cells. And when these epithelial cells accumulate in organized pattern, we call it granuloma. And these epithelial cells, when they fuse, they form the giant cells. Okay, so granuloma is basically organized collection of modified epithelial cells. In the center of the granuloma we see the caseous necrosis, and around it there is proliferation of epithelial cells and macrophages, along with lymphocytes, B cell, T cells. And in active condition there may be also component of neutrophil. Neutrophil comes because of there is activation of T17 cells. Okay, so remember these things. So sometimes, very rarely, amyloid can be deposited in the joint also. Okay, so I think this is enough for you. If there is any questions, please send to my email address, which I have already given, and also you can ask directly to me anytime to my phone number. You can connect my phone number and ask if there is any question. Thank you for your attention and for your patience. Thank you.
Thank you.